Good afternoon, everybody. I want to thank all of you who are able to join us for this live stream today for Medicine Grand Rounds. Before we have other introductions, I certainly want to send a great thank you to the Southeast Michigan Center for Medical Education, Kate Chopra, the Executive Director, and all of their staff who've been outstanding to work with, including lending us their technical support and other skills as well. Without further ado, I'm going to just introduce the speakers for today because I know there's a lot of things to be discussed in the content area. Some operational things before we start. We will be muting every participant, but just in case, please be mindful and mute your own microphones and other devices in case it does not work correctly. We will field questions after the delivery of the presentation. The best way to submit questions is probably using the chat feature through the application that you've hopefully downloaded. We apologize to anybody who had technical difficulties, but the good news is they will be able to listen to this at a later date as we will record it and post it for their listening. Without further ado, I'm going to introduce both speakers real briefly. First is Dr. Teena Chopra. She's a professor of medicine, did all of her training essentially here at Wayne State University, and she is the corporate director of epidemiology for Teena in the Detroit Medical Center, and she probably hasn't slept much over the past week and a half, so we're extremely gracious that she agreed to provide Grand Rounds on this very, very important topic. Assisting her today will be Nabil Al-Kourainy, a junior chief medical resident here at our program as well. Without further ado, I will pass it over to Dr. Chopra.
Thank you, Jared, and thank you all of you for being here. And I think I must appreciate all of you that and our administration and Wayne State Department of Internal Medicine to make this happen virtually, because that is the first principle of social distancing. I also want to really thank the department for making this, the SEMCME department, to make this virtual Grand Rounds happen. Without much delay, I want to start with my presentation along with Nabil. So the title COVID-19 Containing the Contagion was chosen almost 2 weeks ago. But really now it's not containing and it's more mitigating, because we are out of the stage of containing, but we are at mitigation, and we need everybody's help to do this. So I will be discussing some of the backgrounds, and then I will, these are the objectives on this slide, as you can see, and then Nabil will walk you through the risk factors and some of the timelines around the development of this outbreak in China. And at the end, I'll walk you through our preparedness at DMC, which is extremely critical and evolving and changing as we speak. So the first thing is, what is this virus? As you know, there have been a lot of conversation about, is this like flu? Is it like Ebola? So the first thing I want to tell you is COVID-19 is not flu. Why? Because it has some very peculiar characteristics which are unique to COVID-19. What are those? It's very infectious. It's more infectious than flu, so it's not flu. It has a reproductive ratio of anywhere between 2 to 3. Second characteristic is its mortality is higher than flu. Flu mortality is 0.1%. Even if I take the lower range of COVID-19 mortality that we know of at this point, which is a wide range, anywhere from 1% to 15%, as high as 15% in older adults more than 60 years of age. Even if I take 1%, the COVID mortality is 10 times higher than flu. So please know this is not flu. This is also not Ebola. Why? Because Ebola's mortality is as high as 80%. We did witness Ebola already, and we noticed that in Ebola, a patient gets very sick very quickly and is restricted. So there's no time for the patient to spread it. So it's not Ebola. Yes, its mortality is less than Ebola, but it's not Ebola. So the two things we've learned so far, it's very infectious, it has a higher mortality. And third thing, it has come to us at a time where in a population that's not immune. We are not immune to it. So it is coming to us at a time where we are not immune. Number 4, it lasts on surfaces for a longer period of time than flu. So hence, it is very, very different. In a non-immune population, when we see a virus which is unique, highly infectious, higher mortality than flu, no treatment available is the number 5 thing that I want to tell you is how it is different from flu. For flu, we have oseltamivir, we have treatment for flu, we have a vaccine for flu, but we don't have a vaccine and we don't have treatment for this virus. So these are the 5 things that differentiate it from flu. Does this pandemic have a potential? What damage can it do? So I don't want to be an alarmist, but I don't want to cause any kind of panic in our community. But I do want to say that this virus has a significant potential. From experiences from China and Italy, WHO team, when they returned from China, the team said it was a war zone in China. The city was, China was disrupted, Wuhan was disrupted, it was like a war zone, everything was shut. So what is it like then? If it's not like flu, it's not like Ebola, it is very similar to the Spanish flu, the 1918 Spanish flu. And I'll tell you why. First, I want to talk about this slide where you can see this graph where you see the COVID-19 testing per capita. And you can see from here that all the other countries, South Korea, for example, with a population of 51 million, have done so many tests. And we are a population of 329 million. Since on March 8, we had only done 1,700 tests. So this is where I think US is really behind, that we haven't been testing enough. The virus is in our community and we haven't been testing enough. So moving on, and how is this virus similar to the Spanish flu? If you remember, to take you back to 1918, this was one of the deadliest pandemics in human history. 50 million deaths and a drop in global economy by 5%. Both the COVID-19 and Spanish flu, they come from an unknown viral strain with no vaccine and no proven treatments. Both spread through droplets, respiratory droplets, and both of them cause pneumonia and related complications like ARDS and such. Now, what do we do? Where is the answer? We know it is like Spanish flu. What do we do next? It's right here. We are in the midst of a storm. So how is this curve going to affect us? How is it going to treat us? It all depends on how we are going to treat it. The curve, what we need to do is buy time and flatten the curve and buy time until we have a vaccine. It's not magically going to disappear. It's going to stay here for a while until we have a vaccine. Until then, everything depends on how our community responds to this pandemic. That's exactly what happened in 1918. The mortality in 1918 was highly dependent on the speed and the manner of societal response, the social distancing. So in the next slide, you will see a tale of two cities. Very interesting example, Philadelphia and St. Louis. Philadelphia in 1918 during the Spanish flu was very slow to respond. They downplayed their risks. They failed to cancel a big parade where 200,000 attended within 72 hours. The city's 31 hospitals were overwhelmed. There were 12,000 deaths. Whereas St. Louis, the health commissioner shut down the city immediately, even after there was a first confirmed case. Schools were open, schools were closed, events were closed, bars, movie theaters, and the number of deaths was 1,700. So you can imagine the response of the community is so important at this time. Perception of risks. You know, there is a personal risk. I am young, I have a very less risk of getting severe disease, and I am going to get mild disease. So it doesn't matter. I am having symptoms, let me go to the hospital, and when I go to the hospital and shake hands with an older colleague of mine, I will be responsible for giving that colleague a serious illness from COVID and maybe serious outcomes from that. So this is what we need to remember, not personal risk. The perception should be a societal risk that I want every one of us to remember and also to disseminate to our community. So here you can see that COVID, how it compares to the other viruses. MERS-CoV, for example, had a case fatality rate of 34%. SARS had a case fatality of 9.6%, and an average of COVID-19 is 3.4%, but it has a range. It ranges anywhere from 1% to as high as 15% in older adults. Now, this is the next slide. I really want you to look at this slide, and it is a very interesting slide because as the color becomes darker orange, you can see the virus's severity increases, mortality increases. So 1918 pandemic is higher up in the top right corner, and you can see other pandemics are in low or moderate severity. But the blue-purple rectangles show you the COVID-19 estimate severity, and it is variable. For ages 60 or higher, it is very high up, as close to the 1918 pandemic, very severe. Whereas for ages 20 to 59, it is somewhere middle, moderate, high severity, and sometimes very high. Ages 0 to 19, very low severity. This is extremely important based on the studies that have been done in China. This is what we know about its severity, and this is why I will shortly talk to you about at the end, when I get to the end, about visitor restrictions and how we've decided to do visitor restrictions at the DMC. So with this, I would like Nabil to take over the presentation, and I will return again to go over some of the preparedness we are doing at DMC.
Thank you, Dr. Chopra, for that humble introduction. I'm excited to present this topic to you alongside Dr. Chopra. So when we think about COVID, the first thing that you need to understand is the naming of the contagion, because there's been a little bit of confusion, especially amongst our patients, regarding the difference between COVID-19 and this virus SARS-CoV-2. So the important distinction to make is that the disease itself is called COVID-19, typically known as 2019 novel coronavirus, whereas the virus itself is called severe acute respiratory. So in discussing the outbreak and how everything got started, the outbreak initially was linked to the Hunan seafood wholesale market in Wuhan, China, in late December of 2019. However, there have been later claims that call this into question. It appears that there was a case of suspected and later confirmed COVID-19 in a nursing home patient in early December, almost 3 weeks before COVID was first reported by the Chinese government. So that's an important distinction that I wanted to make for you. Additionally, the thought process behind that is that there is a person-to-person spread of the virus, as Dr. Chopra had mentioned, and where does the seafood market kind of come into play? Experts agree that the poor sanitation conditions in this open-air, crowded seafood market likely potentiated the spread in the Wuhan area. So now, in discussing the virus, it's important to discuss, exactly what is the virus, what is the transmission of the virus. COVID-19, caused by the virus SARS-CoV-2, is a novel type of beta coronavirus. It's one of 7 coronaviruses known to infect humans. But it's important to note that coronavirus is, although relatively new to humans, is not new to bats. There's actually over 60 viruses known to bats. In thinking about this and future research, it's important to consider, in light of, it seems, this increased frequency of coronaviruses, of course, starting with SARS and then later MERS, that further zoonotic research is going to be needed to better understand these viruses and their potential to infect humans. So what exactly is the SARS-CoV-2? It's part of the same family as the initial SARS and the later MERS. We know that it causes a respiratory illness from the common cold, a respiratory illness from the common cold, to anything from there to severe acute respiratory distress. The incubation period is known to be, according to research to date, between 5 and 14 days. Additionally, in discussing the transmission, we know that the virus is transmitted between person-to-person contact through respiratory droplets within 6 feet. In looking at the slide here, we can see that the reservoir host for all of these viruses, SARS-CoV-2, SARS-CoV, and MERS-CoV, is the bat. For the SARS virus, the intermediate host was the civet, which is a type of cat, a wild cat, which was being consumed in China as more or less a delicacy. Since the SARS virus, consumption of wild animals in China has been banned. The intermediate host for MERS was the camel. However, the intermediate host for COVID-19 disease is currently not known at this time. There's some speculation that the intermediate host may be due to snake. However, that has not been confirmed. Additionally, when thinking about the transmission, it's important to discuss a concept known as serial interval time. Serial interval is the time between successive cases in a chain of transmission. The serial interval time for SARS-CoV-2 is between 4 to 4.6 days. This short interval, compared with the incubation period of 5 to 14 days, means that the transmission is likely to come from asymptomatic spread, as in shaking hands. Now to discuss the mechanism of the COVID-2 virus itself. So the COVID-2 is an angiotensin converting 2 receptor that's actually highly expressed in the lungs and the heart, which likely explains why we see patients with heart disease, lung diseases such as COPD, who end up having more severe presentations and sequelae from the virus. SARS-CoV-2 infects by binding of a spike protein to the ACE2 receptor. This is the spike protein. This is the ACE2 receptor pictured here. It invades the alveolar epithelial cells, leading to the respiratory symptoms that we've observed. Additionally, symptoms can be more severe, as previously mentioned, for patients with cardiovascular disease. I also wanted to mention that when discussing this virus, as well as SARS-CoV, the initial one, as well as MERS, it's important to keep in mind that it's not the virus itself, but actually the body's immune response that's causing most of the complications and leading ultimately to death in many cases. This is thought to be due to a cytokine storm effect, which is a large reason why drugs that are immunosuppressive, such as chloroquine, are currently being tested and in some cases used in an effort to decrease this inflammatory cytokine response. The cytokines that are have been associated with this response include interferons, interleukins, chemokines, colony stimulating factors, and tumor necrosis factors. These are known to contribute to the symptoms of coronavirus, such as redness, swelling, edema, fever, and pain. Overall, the cytokine storm, during which inflammation spreads throughout the body, for those who are unfamiliar with that term, via the blood circulation, is a common consequence of this type of inflammatory reaction that can lead to severe lung injury and in turn, acute respiratory distress syndrome. In addition, recently, publications have brought to our attention the possibility of the use of medications such as chloroquine, which is an anti-malarial drug. Other immunosuppressives, such as methotrexate, for example, prednisone, have not been widely studied. However, prednisone is not typically recommended for patients with acute respiratory distress syndrome. So in talking about the coronavirus timeline in general, just to echo a couple of points from Dr. Chopra, SARS-CoV was initially diagnosed in 2002. The epidemic ranged for approximately 1 year between 2002 and 2003. It first appeared in November 2002 in the Guangdong province in southern China. The virus led to approximately 8,100 cases with 774 deaths. MERS COVID began on the 13th of June in 2012, and with a patient who was later determined to be patient 0, admitted to the hospital with a pneumonia-like picture, later developed severe acute respiratory distress syndrome, subsequent renal failure, and died 11 days later. The initial physician, Dr. Ali Muhammad Zaki, was the first physician to isolate the coronavirus that caused MERS. And similar to what occurred during the initiation of and discovery of SARS-CoV-2 in China, he was sanctioned by his government for speaking out about the virus, and subsequently was exiled from Saudi Arabia. Now, in talking about the coronavirus timeline, there's been some recent news coming out of the World Health Organization. Just a few days ago, the World Health Organization made the decision that many had been waiting for quite some time to finally designate COVID-19 as a global pandemic. Many experts said at the time that this was overdue, and the WHO Director General, Dr. Tedros Adhanom Ghebreyesus, urged nations to take more aggressive action, noting that with these types of measures, they could detect, test, treat, isolate, trace, and mobilize people into response to try to decrease the transmission of the virus. So just quickly going over the coronavirus timeline out of China, I wanted to pay particular attention to one physician named Li Wenliang. A 34-year-old ophthalmologist was the first physician to identify this cluster of pneumonias of unclear significance that would later be determined to be due to SARS-CoV-2 leading to COVID-19. Dr. Wenliang then published his findings, he posted his findings on social media and was later chastised by the Chinese government for publishing falsehoods, for sending warnings about this deadly virus on social media. In addition, there was the arrest of several physicians in China, and only after about 50 million Chinese people were on lockdown and quarantine did the Chinese government acknowledge that Dr. Li and others should not have been censured. Just a quick quote from Dr. Wen Liang. He said, "It's not so important to me if I'm vindicated or not. What's more important is that everyone knows the truth." Shortly after this quote was given, Dr. Wen Liang, who actually succumbed to the virus himself, died within a week of giving that interview. So going back just quickly to the coronavirus timeline, so initially the first patient developed symptoms, as I'd mentioned earlier, about December 8th. This is still a little bit controversial. Chinese authorities alerted the World Health Organization about several pneumonia cases that they weren't quite clear what they were from. The etiology was undetermined at that time. It's also important to keep in mind that similar to the initial SARS virus, this virus really the outbreak in China began around the time of the Chinese New Year, which, of course, the Chinese New Year is a significant event in China and leads to probably hundreds of thousands, if not millions, of visitors to China on a yearly basis. This obviously was a recipe for disaster. So on January 1st, the Wuhan seafood market that was attributed to a rapid spread of the virus was initially shut down. The first death in China was recorded on January 11th, and the first case reported outside of China was in Thailand on the 13th. Now, this is an infographic from the BBC with information from the World Health Organization, which just kind of shows you how confirmed cases spread outside of China. The number of cases, according to the WHO chief, Dr. Ghebreyesus, cited that these cases increased 13-fold within a 2-week period of time. About 5,000 people have died thus far as of March 13th, 11:42 Greenwich Mean Time. There currently are 137,882 confirmed cases in 13 countries, and the fatality rate is estimated anywhere between 1.2 and 3.5%. However, that number is likely to be overestimated due to a number of cases of patients who have not yet been tested and are likely transmitting the virus via asymptomatic spread. So, talking about the clinical presentation of this COVID-19 disease, these figures are based on the first 1,099 patients published in the New England Journal of Medicine from 552 hospitals in 30 provinces in China through January 29, 2020. And as you can see, fever, cough, myalgias, and dyspnea are the most common symptoms. Fever was associated with 43.8% of patients on admission, but 88.7% during the hospitalization itself. Cough also had a high rate amongst these patients, as did myalgia and fatigue. Shortness of breath or dyspnea was found in 31%. Of note, labs are most significant, and the most common laboratory finding is actually a lymphocytopenia. 83.2% of patients in this study were found to have that laboratory abnormality. In terms of imaging findings, on CT thorax, there are 2 major imaging findings seen in about half the cases. One are ground glass opacities, which we'll see in the next few slides, as well as bilateral patchy shadowing. Patients who had at least one coexisting illness was present in about 24% of patients. ICU admission was required in about 5% of these patients, with mechanical ventilatory support being necessary in about 2% of those patients, and an overall mortality rate of 1.4%. In addition, it's important to keep in mind that outside of these symptoms, there has been some speculation that patients who come in with URI or upper respiratory infection symptoms, that you can rule out those patients from having COVID-19. And this is not supported by the data. A JAMA article looking at about 18 patients out of Singapore noted that several patients had upper respiratory infection. However, they still tested positive for COVID-19. So the take-home point is, if a patient has fever, cough, dyspnea, or any of those features, because it's important also to keep in mind that you can just have one of those features and not necessarily all of them, that you need to take it seriously, and upper respiratory infection does not rule out the virus. So this is just, we're going to go through a couple of imaging findings. This is CT thorax from a 37-year-old. And you can see evidence of bilateral multifocal ground glass opacities on this image. Additionally, this is from a 63-year-old woman who presented with severe symptoms and necessitating ICU admission, which also shows bilateral ground glass opacities. And a third image from a 63-year-old woman with confirmed COVID-19. Patient had a long-term exposure history to Wuhan with characteristic symptoms. Again, you can see the bilateral ground glass opacities here. So in thinking about the disease, who is at the highest risk? We know that elder adults are at higher risk, but also patients with chronic comorbidities. The vast majority of cases out of China, about 87%, were found to be in patients age 30 to 79. ARDS patients had an average age of 61 compared to an average age of 49 for those without ARDS. And elderly patients obviously were more likely to develop ARDS. After taking into account a patient's age and smoking status, data indicates that many patients, particularly 399 out of a study coming out of China, published in the Journal of American Medical Association, found that 399 of the patients with an additional disease, including cardiovascular disease, diabetes, hepatitis B, COPD, CKD, and cancer, had a 79% greater chance of requiring ICU admission or respiratory support. And 130 of these patients were found with 2 or more additional diseases, and 2 or more comorbidities were associated with a 2.5 times risk of these health outcomes. So the CDC has recommended the following if you're a higher risk patient of getting sick from COVID-19. You should be stocking up on supplies. You should be taking precautions. And the term of the day is social distancing, to keep space between yourself and others, doing things like using a different bathroom if possible, making sure that you're disinfecting surfaces that Dr. Chopra had mentioned earlier, and using a different bedroom if possible. Obviously, avoiding cruise travel and non-essential travel. Now to talk a little bit about the diagnostic testing. So the diagnostic testing, initially, the World Health Organization designed a test. The test is a real-time reverse transcriptase PCR testing. In the United States, the CDC opted not to utilize the WHSO test, but to design their own. And this has led to a severe delay in the number of tests that Dr. Chopra had mentioned earlier in the United States compared to, say, South Korea, where they're testing about 20,000 people per day. And part of the reason for this delay is the Center for Disease Control had noted manufacturing challenges during the manufacture of their test, and as a result, that has led to a significant delay. In response, the private sector has made attempts to try to mitigate this issue. The FDA recently approved on the 9th of March both a test from Quest Diagnostics as well as LabCorp. And there has also been independent testing developed by the University of Washington to mirror the South Korean style of drive-through COVID testing. So as the disease progresses and the outbreak becomes more prevalent in the United States, obviously more testing will be needed. In thinking about the diagnostic testing, it's important to keep in mind the manner that testing should be conducted. So at our institution, the recommendation is to use a nasopharyngeal and oropharyngeal swab in either a red top tube or a BD viral transport medium, and then to send those swabs for testing to the appropriate labs. So in discussing treatment options for COVID-19, much like SARS and MERS, there really are no medications that are currently available. And unfortunately, at this time, there's no vaccine that's currently available. And experts estimate that the vaccine will likely be unavailable for at least 1 to 1.5 years. So What do we do in the meantime for these patients? It's important to keep in mind that the goal should be to curb the transmission as much as possible. And I was listening to a live stream webinar today given by Dr. Mauricio Ciccone, who is the president-elect of the European Society of Intensive Care Medicine, as well as the head of anesthesia and intensive care department at Humanitas Research Hospital in Milan, Italy. And as I'm sure you're aware, Milan, Italy has been, and the northern part of Italy has been severely hammered with COVID-19 outbreak. And Dr. Ciccone had the following to say, which I thought was poignant. If you don't take down the transmission of the virus, then the capacity of your system for support will become overwhelmed. And this is the case that Dr. Chopra had mentioned, where China felt like a war zone. The hospitals were quite overwhelmed. And as per our earlier slides, this was also the case in Philadelphia during the Spanish flu. So then, what are the treatment options that we have available to us right now? Supportive care is the mainstay of treatment. Rest and drinking plenty of fluids for those who are mildly symptomatic. Staying at home rather than coming to the doctor's office and potentially infecting others. Trying to stay out of the emergency department if you have mild symptoms, or at least calling your doctor or calling the emergency department ahead of time, or calling the CDC hotline. As I'd mentioned, while there's no drugs currently approved, several have been tried. Antivirals such as remdesivir have been shown to be effective in animals and have been used as a trial drug to treat a patient in Washington State. For patients that develop more severe symptoms, invasive mechanical ventilatory support is going to be your best bet. It's important to keep in mind that we should be avoiding treatments such as steroids and empiric antibiotic therapy, as these have not been shown to decrease mortality in these patients. Just a quick couple of points about what patients need to know, and I want to call your attention to a fact sheet that the CDC has developed, and I would recommend for the clinicians listening in the audience printing this and giving to each patient who comes into the clinic, regardless of whether they're coming in for suspected COVID symptoms or not. They've come out with two major fact sheets. One, what you need to know about coronavirus disease, and the other, what to do if you're sick with coronavirus. So just a couple of points, mentioning things in plain layman's terms, keeping in mind that the average Detroit population has a reading level of 3rd to 5th grade compared to the national of 7th grade. We need to be able to discuss with patients how COVID is spreading person to person through coughing or sneezing or shaking hands, or on surfaces like countertops, toilets. What are severe complications, pneumonias, explaining to patients that that means infection of the lungs, not just saying the term pneumonia, because a lot of people might not know that. Also keeping in mind to take standard precautions like washing your hands regularly for at least 20 seconds. This includes washing both the palms of your hands as well as the back of your hands, and especially under the nails. And if you're not able to wash your hands and have soap and water nearby, then an alcohol-based hand sanitizer with at least 60% alcohol is recommended. This is a second info sheet that discusses what to do if you're sick. And the highlights are to stay home, call ahead before visiting the doctor, and seek medical attention if symptoms worsen, calling first, and then wearing a mask. And with that, I'm going to transition back to Dr. Chopra, who's going to go over the DMC COVID-19 inpatient algorithm. Thank you for your attention.
Thank you, Nabil, for a wonderful job and explaining the risk factors and also going over the diagnostic and the treatment modalities of COVID-19. So now I want to walk you through what we are doing at DMC and how prepared we are, because this is a real metal, right? This is what I started off with. How are we going to respond? What are we going to do? And how are we going to face this storm that we are in? First of all, if you've noticed at the DMC, the leadership at DMC has done a wonderful job, have been very, very proactive, and have been very preemptively taking steps even before we have actually seen a positive case here for almost the last several months. Now, as you notice at the DMC, every entrance we have hand hygiene stations. Every entrance we are screening our visitors, screening our employees, screening anybody who's entering the entrance, entering the hospital. We've also developed several pathways and algorithms to to help our frontline providers. So the first aim is to safeguard and protect our frontline providers, our EDs, and our clinical, hospitalists and internists who are seeing patients at their clinics or in the EDs or urgent cares or community clinics or any clinics that are associated with our hospital. This pathway that you can see here is an inpatient algorithm pathway. What happens if we are suspecting a patient, for example, meets the patient under investigation definition, and the clinician, at this point, keep in mind, CDC has loosened criteria and really the travel history is a blur, because even if the patient hasn't traveled, there can be community spread and you can suspect a COVID-19 in a patient. So the first thing you do is you notify the house supervisor and the chief nursing officer. We've created a COVID starter kit, which includes a special pathogen sign to go on the door, a PPE poster, a form that has to be filled out, 2 collection swabs with viral transport media, face shield, surgical mask. And there is a lot of this information has been communicated with the entire staff with photos to walk you through. And you order airborne and contact precautions. This patient is, if you're suspecting, you put the patient in a private room, place a surgical mask on this patient, keep the door closed at all times, and you go from there. If you are not suspecting that this is a PUI patient, then you don't have to do any of those. So that's how the pathway is walking you through. Now that you have suspected this patient to have a potential COVID, you first start with your flu test if it's not done. Keep in mind that these patients, if they are flu positive, they cannot have COVID. There is data from China and from others that have shown that you cannot have co-infection. It is very, very rare to have that. So once you know that this is not flu, then you can move on and you can do the COVID test with the swabs that we have mentioned, call the MDHS state and get a PUI number for them, draw the swabs, collect both oropharyngeal, nasopharyngeal swabs, put it in the same viral media, hand deliver it to the lab, and from the microbiology lab, they will actually courier it to the state. If the flu is positive, you stop there and follow the influenza protocol, which has been communicated with you before. Very important things that I want to mention here. We don't want our medical students to enter a PUI room. So the AAMC has sent out a communication that we cannot have medical students enter this room. Please keep that in mind as well. All the hospital infection control practitioners are very well versed with this pathway, and you are allowed to call them at any point when you are in doubt, and keep in mind to protect yourself first, because we don't want any of you to be quarantined at home. You will, in the next slide, find these assessment criteria which we've created. It's almost like a mathematical formula. It is very much being followed in the ERs these days, has been done for the last 2 weeks. These are the criteria, as you can see. A is, does the patient have fever? B, does the patient have cough or shortness of breath? C, does the patient require hospitalization for severe ARDS pneumonia? D, has the patient tested negative for other common pathogens like influenza? E gives you 1 and 2. 1 is your close contact with a COVID patient and 2 is your travel. CDC's travel at this point definition gives you international travel. But we at DMC have expanded it because we want to flatten our curve here in Michigan, and we have expanded our definitions to include domestic travel to Washington State, California, New York State, and Massachusetts as well. So we are going to consider travelers from these states within the last 14 days as potential patients under investigation. Suspect COVID, if you have answered yes to either A or B and E1, or A or B and E2, or A and B and C and E2, or A and B and C and D. So this has been given to you, provided to you to go over, and clearly mathematical formula if you are in doubt. I can give you an example. Today I saw a patient who has in our hospital who has HIV and has bilateral opacities, has no history of travel, but has shortness of breath and in the ICU and fever. So the patient is actually meeting your A and B and C and D criteria, and so we have decided to test this patient. So that's a perfect example. Moving on, you can see over here, the Johns Hopkins website gives you a heat map, very nice resource if you want to see the statistics where we are. This is the first one, is giving you global total numbers, total confirmed COVID cases globally, and then total deaths 4728, and this is actually not very current for this time, but it is close to being current. The next one shows you 17 for the US, 1700 cases and 40 deaths. As you know, the things are moving extremely fast and evolving. Right this minute, I'm not sure what the number is, but this pretty much gives you an idea that we are not talking about days, but we are talking about hours over here. Also, I want you to know that it's not like we are discovering these cases. It's just like we are increasing as we will increase more testing, we will find more cases. These cases have been there in our community for a while. To give you an example, if there is a county or a country or a state where there is one death, that means that the virus has been circulating over there for a month. And I'm not making it up. This is like a very simple math. So it takes about 5 to 7 days for the patient to show symptoms. After that, after the symptoms are shown and the patient presents and the patient is tested and the patient, let's say, gets severe illness and dies, it takes another 18 days. So by the time that the patient dies, there's one death. In the community, there are at least 100 or more cases already. Our numbers are increasing as we are testing more. So please keep in mind that it is important to test whenever we are suspecting, whether we are outpatient, seeing our patients. There are more testing kits that are being available as we speak, and there are more tests that FDA has approved this morning as well. Now I want you to look at this slide, which is actually showing you the confirmed cases in Michigan. I think you're all well aware. We have 12 cases that are confirmed in Michigan, and some of these cases are associated with travel. There has been a nice communication where they have shown that these patients have traveled, but some of them are not associated with any travel. For example, there are 3 individuals from Oakland County, and out of them, one of them has no history of any travel. This is a good resource for you to look at what is happening in the state of Michigan to get updates on where we are with the testing and with the positive results. Now, these are some media myths that I think as physicians we have a responsibility, and we want to make sure that we don't propagate them, and we try to stop them as much as possible, because again, it depends. This is How how this pandemic is going to act, it depends on how we are going to behave. We have to be united, and we have to take steps which are positive and in the right direction. There have been numerous Facebook posts that have advocated eating garlic. WHO has given a statement. There's no evidence that garlic can protect people from new coronavirus. Drinking water every 15 minutes, again, myth, heat and avoid ice cream. All of those are again myths. We must learn lessons. We must learn lessons from Seattle. We must learn lessons from Italy. We must learn lessons from Korea, and also lessons from Singapore and Hong Kong, which have been very, very successful in flattening their curve. For example, Italy, 2 weeks ago, they reported their first case, and now there are over 10,000 confirmed cases with over 631 deaths. So it's a cautionary example. Contact tracing, isolating, identifying, informing is what is the key. Singapore, Hong Kong, very good examples. Another important thing, younger individuals are at high risk. Yes, they get milder illness, but don't forget the example of the Diamond Princess ship, where incidence of individuals with less than 20 years was same as in individuals more than 20 years of age. So younger children can be affected. So that's why we have witnessed this mass school closures yesterday. The epidemic can very, very rapidly amplify. A death, like I said, signifies that the virus has been circulating for at least 1 month. Look at what happened in Washington, Seattle, in nursing homes. The virus was already there. We've talked about these recommendations. I can't stress enough. Nabil did a great job in explaining what should you do when you get it. These are CDC recommendations, and I want you to remember staying at home if you're sick, coughing, sneezing with a tissue or a sleeve, avoiding close contact, hand washing. I cannot stress enough. These are some of the travel recommendations. These are, I would direct you to the CDC website. And I also want to make some important remarks here. This is not the zombie apocalypse, but it is serious. We cannot promote panic in our community. We have to avoid any kind of noise so we can be unified as a community. We can be unified as a health system to help mitigate this and help flatten the curve. Again, how it affects us depends on how the community responds. It depends on us. We must identify cases, educate the public that social distancing and self-isolation are keys to prevention of spread. Be more proactive rather than reactive. Risk perception, like I talked about in the beginning, it is not a personal but a societal risk that we should be talking about. Younger people can also be affected. At this time, as a healthcare facility, as a healthcare institution, as physicians, it's very important that we remember the key lessons we've learned from outbreaks in Washington, outbreaks in New York. And one of them is, don't wait. You want to act when you have to have closures, for example, which our governor very rightly did. Another one is protect the elderly. Very, very important to protect our elderly and make sure that we enforce our visitor restrictions as we have done at DMC. We have allowed 1 visitor per patient, and we have restricted our visitors to between 19 and 59 years of age as well. I also want to say, yes, WHO has compared this to a war zone, and yes, that this is a storm and this is very serious. But what baffles me is how our community is reacting. How sometimes, for example, grabbing every roll of toilet paper from Costco shelf and hoarding it in your truck. All of these examples being politically biased. All of these examples are not what our community should be doing. There is good news. What is this good news? This eventually will pass, but we will have to go through it. We have endured worse. It is not, yes, it is akin to war, but it is really not shipping our families off to war. It is not causing us to lose our homes, and it is also not threatening to blow up any buildings. It is upsetting, it is disrupting life, but we have to live through it, and we have to be united. With this, I would also like to end by telling you what is coming next. Some of these next steps that we are instituting at DMC are applying principles of telehealth in our outpatient clinics. Drive-through testing has already started in our EDs. We are creating a COVID hotline, and we are creating a COVID clinic at DMC. So important thing is flattening this curve. As you can see, we don't want, we are in the logarithmic stage of this curve, and we want to buy time to flatten it so that we can have enough time to get there where we have a vaccine. With this, I would like to be happy to take questions, and I want to thank you all for being with us today.
So, Dr. Chopra, thank you so much for that succinct presentation, especially with regard to the DMC-specific protocols that all of us will be utilizing, I'm sure, in the near future. The first question is from Aaron Miller, and Dr. Miller asks, is there guidance to help outpatient doctors effectively triage patients to limit ED/inpatient resource utilization?
This is a great question. Yes, we have an algorithm for outpatient clinics. As we speak, we are going to be circulating it to the clinics very soon so that we can triage and we can funnel the patients away from the ED. Also, these COVID clinics that we are establishing are going to make a huge difference.
So another question asked by Thomas Kelly. Dr. Kelly asks, other hospitals in the area are canceling elective procedures. What is the criteria, if any, for us to consider that?
That's a great question. We have a backup plan to do that, and that is also ready. The algorithm for that is ready, but we will trigger it when we will get there. DMC administration is doing a wonderful job working very closely with myself and the infection control team here, and they are very much in line with our recommendations. We may do that, and we are ready for it.
The next question comes from Tony H. Tony H. asks, do ACE inhibitors have any effect, positive or negative, in the treatment of the virus, or could they potentially make them worse?
That's a great question. We don't know. There is some data out there that, with ACE inhibitors, especially because the virus has these spike proteins that attach to the work through via the ACE mechanism, there is some speculation that it can help, whereas there is some speculation it can make it worse. We don't know at this point.
Another user asked, why did the U.S. opt not to use the WHO test, but instead the CDC decided to develop their own? Do you have any specific knowledge on that, Dr. Chopra?
I'm sorry, I'm not familiar with why the decision was made by U.S. to do that.
Okay. Another question is with regards to treating younger patients, particularly out of Children's Hospital, and the question asks, it's common for children to test positive for more than one virus. How can we utilize this adult algorithm or the algorithm that you earlier presented to stop investigation without a negative COVID-19 test?
That's a great question. Yes, children can have other viruses like RSV, human metapneumovirus and such, and we in fact had a patient over one of the weekends where the patient ended up having human metapneumovirus. So children's algorithm to give you a short answer, the algorithm is different. It's being modified and it's being communicated as we speak to make sure we do the RVP panel in children before we can go to the step where we are going to do a COVID test.
In terms of testing, one user asks, is there or will there be drive-through testing available at DMC? Is that currently under development? I believe this is Michelle Brock, who's a program coordinator over at Children's. Thank you, Michelle.
Michelle, thank you for asking this question. DMC has already done some drive-through testing in the EDs. We've done several, and we have loved that example, taken it from Seattle, Washington, and several other South Korea, and we are trying to build the same even for some of our clinics. We are working on it as we speak. There is a whole task force that is working on COVID clinic. There is a task force working on drive-through clinics. There's a task force working on hotlines. And I will be reviewing all the scripts that we have to use when we do this triage and screening process.
The next question comes from Anton, and forgive me if I mispronounce your last name, Gaustin, who asks, do sick COVID cases get secondary bacterial pneumonia, similar to what we see with patients that recover from influenza and then subsequently develop secondary staph infection, Dr. Chopra?
Yes, that's a great question, and the data has shown that they can develop secondary bacterial pneumonia and co-infections with bacteria, but co-infections with other viruses are very rare. So that's why we can stop the algorithm where the flu test turns positive. So this is a great question.
As a segue to the comment about flu testing, another user asks or comments that local urgent care is empirically treating for influenza without testing. For patients that improve with Tamiflu without influenza testing, should we be testing those patients for COVID?
That's again a great question. If they have milder symptoms at this time, the message to the community is to for those patients to stay at home if they have milder symptoms. But yes, patients can ask to be tested, and they should be tested if they want to be tested for COVID. Or they should first be tested if they have milder symptoms and they say, we want to know what we have, then they should first be tested for flu, and if it is negative, they should be tested for COVID.
All right. Additionally, there's been some questions, because there's no treatment available, obviously, at this time, Dr. Chopra. We had mentioned chloroquine earlier and other immunosuppressives, but what are your personal thoughts on the use of these medications for treatment of COVID-19?
That's a great question, and I started looking at chloroquine almost a month ago when it was actually used in a few patients in China and South Korea, along with some antiretrovirals. And what I learned was in animal models, chloroquine inhibits the binding of cytokines to tight junctions in the alveolar epithelial cells, and that's how it inhibits the cytokine storm, and that's how it works. So there's a pathophysiology around it, and there's a mechanism around it, and it's been used as a cocktail to treat some of the patients who are very severe. So of course, if we have such a patient, we would resort to first using compassionate use of the remdesivir from Gilead first. And if, we need to, we may resort to chloroquine as well.
For the next couple of questions, I'm going to let Dr. Chopra take a little break. One of the users asked, I believe this is Dr. Gupta, is there a role for ECMO? And actually, Dr. Gupta, that's an excellent question. As I'd mentioned, the live webinar that I attended just this morning with Dr. Mauricio Ciccone, the president-elect of European Society of Intensive Care Medicine, that question actually was asked. And Dr. Ciccone commented that ECMO is reserved for a very small subset of patients. It's important to keep in mind that the use of ECMO is not going to be specific for COVID-19, but in general, if you're having a patient that has ARDS or some other complications that you're not able to curtail the symptoms and improve the patient's clinical status with traditional methods such as ventilation, proning, etc., then ECMO can be considered in these patients, but it should be reserved for those. Additionally, there's a question regarding, is there any recommendations for or against testing in bacterial pneumonia? So in the event that a patient is diagnosed with a bacterial pneumonia, should we also be testing? So it's important to keep in mind when treating these patients that if there is another cause for the patient's symptoms that's not related to COVID and say identified by same staph pneumonia, then you would treat those patients as you would treat any other staph pneumonia, and you would not then need to. Would you agree, Dr. Chopra? Then go and test for COVID-19. I think this is a very important point, and thank you for the user for asking this. The reason for it is we really need to limit the amount of. We have a limited number of resources, as we mentioned earlier, even with the great delays in testing that we've seen in the United States. So we don't want to overwhelm laboratories with tests that are unlikely to yield a COVID-19 diagnosis when we have a diagnosis of bacterial pneumonia from other testing that we can do locally. Another user asks that China is reporting a decline, businesses are reopening. What does this mean for the U.S.? Can we expect a decline in 4 months or sooner because of the season? You know, it's really tough to say what's going to happen. In Italy, for example, part of the self-isolating and social distancing measures has been to shut down most stores, if not all stores. I just saw a news report by Emmanuel Macron, the president of France, who mentioned that all museums are going to be closed. So I think things are going to have to be taken on an hourly basis, on a daily basis, and on a weekly basis, and things will be adjusted accordingly. However, based on previous pandemics, we know that up to 8 weeks of this type of social distancing and social isolation, for example, the 1918 Spanish flu, those seem to be more effective in flattening the curve.
Yeah.
Dr. Chopra would also like to comment on that.
Yeah, so I agree. This is a great question. The virus will stay. It won't magically disappear, but it will slow down depending on how we treat it, how we behave, how we take those measures like Nabil said. So it's a good example that you gave of China, and Singapore and Hong Kong, for example, have flattened their curves. It won't completely disappear. It will stay, and there will be small outbreaks here and there where people are not taking precautions. So we have to be very, very cautious all the time.
Another user, Omid, asks, don't we need to wear masks during our clinical practice, specifically when we're in the ED? And I think it's an important point, Omid, and thank you so much for your question. It's important to keep in mind that the general mask, the non-N95 mask, should be worn for any patients with symptoms, and that's to protect the spread to others. However, patients or doctors who are not symptomatic, don't have any type of symptoms or diagnosis of COVID, obviously, or they'd be in isolation, that there's no role for the general mask for those patients. In general, in the ED, should everybody be wearing an N95 mask? The answer so far from the data that's provided internationally is absolutely not. And the reason for that, again, has to do with limited resources. You know, we don't want to run out of N95 masks and then we don't have enough for the patients that are truly diagnosed with COVID-19. So that's an excellent question. Thank you so much for that. Another user asked, do all healthcare workers in contact with a suspected patient currently being tested need to be placed in isolation? I'll let Dr. Chopra answer that one.
Can you please repeat the question?
So do all healthcare workers who have been in contact with a suspected or a patient under suspicion for COVID-19, do those healthcare workers need to be tested? A,
Yeah.
and B, do they need to be placed in isolation pending the result of that test?
Yeah, if there is a significant, depends on the type of exposure. If you have been in close contact with that suspected patient, in contact with their secretions or aerosols or within 6 feet, yes. If not, then we will not. I want to quarantine you, and we will wait on the test results and accordingly decide in the pathway what to do next.
Another question comes from Philip, and he asks, is there a recommendation, as we're all healthcare workers, for how long we should be social distancing ourselves from friends, family members, elderly, high-risk groups, even after the outbreak begins to subside?
That's a great question. So first thing is, like I said, protecting our elderly and high-risk individuals. So those individuals have to socially distance themselves. So if you have kids in the house and you have grandparents in the house and the kid is, your kids are sick or they have a mild illness or an URI you want to isolate them from the grandparents, unfortunately. for the time being until they are well, until the child is well. The grandparents have to avoid going to grocery stores. They have to stop going to churches. This is all under the umbrella of social distancing. They have to stop going to regular non-essential visits like getting their toes clipped or getting their teeth cleaned or getting a regular eye checkup. All those can wait. A lot of these can be done over the phone. Prescriptions can be gotten over the phone. Refills can be gotten over the phone. They should not go to pharmacies to pick up their refills. So that's where we are at this point.
And perhaps, Dr. Chopra, one of the things we can utilize is there's a number of mail order pharmacies. So for the near future, we can recommend that patients get their medications through mail order pharmacies and delivery rather than going in to the pharmacies themselves, especially patients who are on multiple medications and have polypharmacy. Those are likely the ones to be at the highest risk of contracting COVID-19. I think we'll take one more question, and then we'll end things. And we thank you so much for your patience and all of the wonderful questions that have been asked. And this is a DMC-related question. Is there a way for healthcare workers to be tested so that we do not need to be self-quarantined in the case of a mild URI, so that we can make sure that we're available to take care of our patients?
Great question. Answer is yes. If in such a case, we have drive-through testing in the ED, and we will swab you, and we will ask you to wait for 1 day at home, and then we will send the test results, and after a day we'll get the results. Accordingly, we will either bring you back or let you be at home, depending on the results of the test. Yes, we have that ability, and we've already done that.
Okay. Any final questions?
Okay.
Okay. Thank you so much. Just for those who are listening, we will be posting the recorded presentation to the Wayne State School of Medicine streaming site. That should be available later today, if not tomorrow. Also, there was a question earlier about the CME ID, so I'm just going to put that into the chat. The CME ID is 181404, so that you can receive credit. Once again, CME ID 181404. Thank you, everyone, for your participation. Thank you, Dr. Chopra, for your expertise, and thank you for listening.
Thank you, everybody. Thank you for joining us. Have a great day.
Stop the share. End the meeting?